Hello and welcome to another lecture on Cushing syndrome. So Cushing syndrome, let's dive right into it, shall we? So this is a scenario that I want to take you guys through so that you get an idea of how a patient would present to you in the clinic. Um, you know, and then when this lecture is over, then you guys can give me your answers in the comments down below. Okay? So a 72-year-old woman comes to the physician for symptoms of dry mouth and polyuria. She has been in good health except for minimal weight loss. She is a former smoker and takes no medications at all. Physical examination shows a rounded face, central obesity, thinning of skin, and violaceous stretch marks on her abdomen. Her random serum glucose is 178 milligrams per deciliter. Which of the following is the most likely cause of these findings? A. Can it be the adenocarcinoma of the lungs? B. Can it be the lactotrophic adenoma of the pituitary gland? Or C. Can it be a pheochromocytoma, which we discussed earlier, in one of our earlier lectures, or a small cell lung carcinoma, or a squamous cell carcinoma of the lungs. So now, as we go through this discussion on Cushing syndrome, we will find the answer. You guys, I know the answer, but you guys will find the answer to this question at the end of this lecture. Definition: Cushing syndrome. Cushing syndrome is basically a condition that is characterized by excessive production of glucocorticoids, namely cortisol, because cortisol in human beings is the major glucocorticoid, resulting in elevated serum cortisol levels greater than 10 to 20 micrograms per deciliter, right? So whenever the cortisol levels rise within the serum, beyond 20 micrograms per deciliter, then it would result in Cushing syndrome. Causes. What can be the causes for the development of Cushing syndrome? Well, the causes for the development of Cushing syndrome include either excessive, exogenous, iatrogenic administration of cortisol. What does this mean? What does this large statement mean? This large statement basically means that sometimes a doctor or a nurse that is administering cortisol to a patient for the treatment of, maybe adrenal insufficiency or something like that, then, sometimes the amount of cortisol that needs to be given to the patient, becomes very high, iatrogenic, and so that excessive amount of cortisol given to the patient, right, it becomes iatrogenic or injurious to the health of a patient. So that is why it can cause Cushing syndrome. Apart from that, an adrenal adenoma can cause Cushing syndrome by producing excessive amounts of cortisol, but independent of ACTH secretion from the pituitary gland, because in this case the adrenal gland itself, because of the adenoma, is producing excessive amounts of cortisol, right? So therefore, it will negatively inhibit CRH secretion from the hypothalamus and ACTH secretion from the anterior pituitary, right? Resulting in low ACTH levels and elevated serum cortisol levels, right? An ACTH secreting pituitary adenoma is one of the other causes for the development of Cushing syndrome, and if this is the cause of the Cushing syndrome, then the condition is labeled as not Cushing syndrome, but Cushing disease, for reasons which I do not know. Okay. In this case, both serum cortisol and ACTH levels will be elevated. Why? Because, as the name suggests, it is we're dealing with an ACTH secreting pituitary adenoma, an adenoma that secretes excessive amounts of ACTH, and then it overstimulates the adrenal cortex to synthesize and secrete excessive amounts of cortisol. Then we have an ectopic ACTH secreting tumor, right? An ectopic ACTH secreting tumor can also, result in elevated serum cortisol levels. For example, a small cell lung cancer, right? And once again, in this case, the ACTH levels will be elevated along with elevated serum cortisol levels. Why? Because ACTH is not being secreted by the pituitary gland. It is being secreted ectopically, right? So therefore, the normal negative feedback inhibition process won't work on ectopic ACTH secreting, tumors. So these are the clinical features of Cushing syndrome in a nutshell. Let's start with the head. So the patient will have acne on his face, thinning of hair. Why? Because hair is made up of keratin, right? And keratin is a protein. So before we dive in further into the clinical features, we need to know that excessive levels of cortisol within the blood, what they do is they basically enhance protein and fat catabolism, which is the breakdown of fats and proteins, right? And they have an anabolic effect on glucose. They tend to increase serum glucose levels, resulting in hyperglycemia, predisposing the patient to diabetes mellitus. So, on the other hand, the protein catabolism, due to the excessive cortisol, will result in muscle wasting and thinning, right? It will lead to muscle wasting and thinning, muscle weakness. It will lead to thinning of hair because of the loss of keratin production. It will lead to thinning of skin all over the body because of the degradation and loss of collagen, right? Collagen, resulting in the development. And because the skin is now thin and friable, therefore, stretching of the abdomen because of central obesity will lead to the development of purplish striae on the abdomen, right? Which is a characteristic classic sign of Cushing syndrome. And because of fat catabolism, all of the fat will then be broken down, right? And all of that, all of the free fatty acids, once they enter the bloodstream, they will then be redistributed to various areas of the body. For example, the trunk, the torso, resulting in the buffalo hump, so truncal obesity or central obesity, right? Okay, so, and similarly, since elevated serum cortisol levels, what they basically do is they basically bind to the mineralocorticoid receptors on the renal tubular cells, right, in the collecting ducts. So they will mimic. So in this way, the cortisol will mimic the action of aldosterone, resulting in the excessive retention of fluid and sodium, right, resulting in edema, right, of the face, resulting in a moon fascies, right, resulting in maybe pretibial myxedema, right. Okay, what else do we have? The patient of Cushing syndrome or Cushing disease will also experience features of hypogonadism, right? In males, features of hypogonadism can be gynecomastia, impotence, decreased libido, right? In females, menstrual irregularities, dyspareunia, vaginal dryness, right? Anovulation, infertility, right? Similarly, the patient will also experience slow wound healing because coagulation factors are required, and coagulation factors require proteins to develop, right? So these were the clinical features, and one more thing, the patient will also experience hypertension because of the reason mentioned earlier, which is the binding of cortisol to the mineralocorticoid receptors. How do we diagnose Cushing syndrome? Well, Cushing syndrome can be diagnosed on the basis of a diagnostic algorithm that I have mentioned down here below, right? So if a patient comes to us in the clinic, right, with symptoms of hypertension, and we see signs of moon fascies, a buffalo hump, a truncal obesity, purplish abdominal striae. The patient says that I have an increased tendency to bleed. I bleed in different areas even though I have not been injured, right? And I have, if she, yeah, if she's hyperglycemic, if she says she is hypertensive, then we will suspect that this patient is, might be suffering from Cushing syndrome. So in that case, we begin our diagnosis of the condition by a low-dose dexamethasone suppression test, which is taken overnightly, right? Or a 24-hour urinary free cortisol. So why do we do this test? Well, how is this test beneficial to the diagnosis of Cushing syndrome? Well, normally when cortisol is being secreted into the bloodstream, it binds to a protein called cortisol binding globulin, right? And this cortisol binding globulin then transports cortisol to its target tissues. In Cushing syndrome or hypercortisolemia, the cortisol levels are elevated, right? And not enough cortisol binding globulin is present within the blood to bind to all of that cortisol, right? To bind to all of that cortisol, right? So therefore, the 24-hour urinary free cortisol might be elevated in Cushing syndrome, right? So if both of these tests, if after having done both of these tests, the cortisol levels remain elevated, then we suspect Cushing syndrome, and then we will measure the ACTH levels. Yes. Then we will measure the ACTH levels, right? If the ACTH levels are normal or low, then an adrenal adenoma is suspected. And I have discussed why ACTH levels would be low in case of an adrenal adenoma as the suspected cause for Cushing syndrome. Then we will order an MRI to confirm the diagnosis. If the ACTH levels are high, then it may either be an ACTH secreting pituitary adenoma or an ectopic ACTH secreting tumor. In order to narrow down the diagnosis further, we will do a high dose, not low dose, a high dose dexamethasone suppression test. If the cortisol levels are elevated, then it's an ectopic ACTH secreting tumor, right? For example, small cell lung carcinoma. If the cortisol levels decrease, then it might be an ACTH secreting pituitary adenoma. In this case, we'll then order an MRI to confirm the diagnosis. An MRI or a full CT metastatic workup, right? Treatment depends on the underlying cause. If it's an adrenal adenoma, then we will simply remove the adrenal glands, right? And an adenoma affects only one of the adrenal glands, not both. Transsphenoidal pituitary ablation with a radiation therapy for a pituitary adenoma, and surgical removal or palliative treatment for an ectopic ACTH secreting pituitary tumor. And if the reason for Cushing syndrome is excessive exogenous iatrogenic cortisol administration, then we will slowly withdraw cortisol. Thank you so much for your time.